Ladies and gentlemen, colleagues, welcome to the second Convatec webcast. I'm your host, Junpyo Hong, the head of plastic surgery at Assam Medical Center. And before we begin our scientific session, I would like to thank the organizer, Convatec, in putting this meeting together with Assam Medical Center, providing new insights and answers to challenges we face today in wound care. Some of you still may be skeptical about using silver against tough wounds, but some of the evidence presented by literature has shown to be compelling. Personally, I find it extremely useful in treating diabetic foot problems, frequently infected with challenging organisms. There are a large volume of papers covering this topic, and the truth is we don't have time on our hands to read all these materials. It is why this webcast presents value in reviewing the essence of silver in wound healing and presenting the most important evidence related in vitro as well as in vivo data. It is with that question and challenge we better treat these tough wounds that we are here today at Assam Medical Center, Seoul, Korea, to talk about the reality of wounds and practice based on evidence. We are gathered here on the floor, over 50 people from 10 different countries. On the live webcast, we have participants from all over the world, over 30 countries, over 3,500 people viewing this live webcast from the US to New Zealand. In our practice, we are challenged with various wounds. From burns to diabetic foot ulcers, no wound is ever the same. In Korea, when Convatec first introduced the revolutionary hydrocolloid dressing back in the mid-90s, this changed the paradigm of wound management. I recall being a resident back then, and I had to change dressings 4 or 5 times a day, saline soaked with gauze, and that was very painful, not only to the patient, but to me. I had to change about 20 patients, and that basically took my whole day. And when this hydrocolloid dressing was introduced, it was a revolutionary dressing and a miracle to see that dressings can be maintained moist without the risk of ascending cross-infection. We have come a long way, and now dressings are customized based on main purpose of the dressing. However, infection still remains to be one of the major problems we face today. Bacteria growing resistance and wound getting tougher to heal. Today, we have 2 distinguished panelists who will further share their experience and evidence on using silver. From China, Professor Jin Ling Quan, Director, Department of Burns and Plastic Surgery, Rujin Hospital, Shanghai, Jiaotong University. And from United Kingdom, my good friend, Philip Bowler, Director, Infection Prevention Research and Development, Convatec Wound Therapeutics. They will give their extract work in this field. After the presentation from our 2 panelists, we'll open to the floor and to the audience over the webcast on any questions that they might have. For the webcast audience, you could ask questions directly through your webpage. So without further delay, I would like to present our first speaker, Dr. Jin Ling Quan.
And at first, I would like to thank Dr. Professor Hong, an organizer of the Convatec company, invited me to stand here to discuss something about the silver dressing. And first, I want to introduce myself. My name is Jin Ling Quan, come from the Shanghai, the Rujin Hospital in the Department of Burns and Plastic Surgery. You know, the burn department of Rujin Hospital was the first burn center in China, founded in 1958. Now, the burn department in Rujin Hospital is one of the 5 biggest burn center in China. So today I'm going to talk about something about the topical silver interpregnated dressing and the importance of the dressing technology. As we know, the the silver has been widely used in medicine for many, many years. And the silver, the first silver, topical silver agent used in burn wound is last century, 1960s. The Dr. Fox in the United States used SSD, silver silverizing, in the burn wound. Even now, the SSD has widely used in burn wound management in China, also in the other countries. Recent years, many kinds of the silver dressing have been become available. I think this is a revolution in the wound management. Also, the modern silver dressing has been used for more than 10 years, but some doctors or some person think about that, the modern silver dressing just a simple combination of two technologies. One is a dressing, another is silver. These sort ignore the intrinsic value of the carrier dressing. Actually, in the fact, the carrier dressing is not a simple passive delivery vehicle for the silver from the dressing to the wound. So the carrier dressing has a contribution sometimes in some kind of dressing. It has a great contribution to make a successful clinical outcome when used in the wound. So when we choose a kind of dressing, we often think about what kind of characters the dressing have. Normally, in the clinic, significant dressing attributes should have like these. These kind of dressing have ability to manage the exudate, can absorb the exudate, and also can minimize the pain when the dressing change. Also can maintain the moist environment for the wound. Also have ability to reduce the maceration of the surrounding skin. And also these kinds of dressing have ability to maintain the contact with the wound band closely, and also can promote autolytic debridement and also sequestrate bacteria and kill them. And finally, can binding the matrix metal proteases. So in the clinic, when we choose the dressing, besides think about the characters of a carrier dressing, we also think about other things such as delivery kinetics of the silver from the dressing to the wound, and also need of the wound at any given time. Now first, let's look at how dressing techniques can assist in the managed pain. As we know, the pain and wound trauma is very often to occur in the time when the dressing change. So it is very important for a kind of dressing to have an ability to avoid or to minimize the pain when the dressing change. What kinds of the factors that are dealing with the pain? And there's three factors including these. One is dry out dressing, these everybody to know. And the second is products contained in the dressing. These kinds of products maybe is irritative, and when we dressing change, this kind of products can adhere to the wound and to causing the painful or causing some feeling of the burning. Finally, the dressing itself is adhesive. And when we change the dressing, this kind of dressing can stick to the wound. When we remove the dressing, sometimes this new skin will be tear off along with the dressing. So these patients will feel very painful in this time. So any kind of dressing that has ability to avoid these kind of factors can have ability to can reduce the pain and minimize the wound trauma. In a clinical trial, RCT trial, Dr. Hiding evaluated two kinds of the dressing used in the chronic ulcer. He found for the easy of removal of the dressing, he found 51% of hydrofiber group was rated as excellent, but only 24% of the aginated group was rated as excellent. Also, 82% of the hydrofiber group has no pain feeling when the dressing change, but 62% of the aginated group has no pain. So this difference is significant. Also, in the group of the hydrofiber group, less adherent and less resistant in the wound when they change. So all of these suggest that the hydrofiber dressing have ability to minimize the pain and minimize the trauma to the wound bed. And let's look at the value of close association with association of dressing with the wound bed. As we know, the wound bed is not regular in topography. So when applying the dressing to the wound, sometimes there is some dead space left. This dead space is place the bacteria like to live, and sometimes the wound infection comes from here. So if the dressing have ability to contact with the wound bed closely, so it has ability to minimize the dead space and also help to promote absorption of the wound juice. Also can help to promote availability of the silver to the wound bed. In the study with chronic ulcer, scientists found that when used Acrocell, a kind of hydrofiber dressing, there's some gel matrix formed, and this kind of gel matrix can mold itself over the wound surface and also can eliminate the dead space. In another study of the two kinds of dressing on the human tissue seated with the bacteria, the results show that there's excellent conformability of the Acrocell agent dressing. And there's less evidence with the other kind of the dressing. Let's look at how dressing technology can assist with the fluid management. As we know, the moist environment is important, is necessary for the wound healing, but excess moist is harmful. So if the excess moist at the dressing interviews are not managed correctly, the optimal wound healing will be compromised. So not only the good dressing absorb the exudate, but also this kind of dressing should have the ability to retain the fluid and ensure that the para-wound skin is not at risk of maceration. Now, another study, the person investigates clinical performance of several silver-containing dressing, including the fluid handle properties. The results show that the best fluid retention under compress was achieved by the hydrofiber and also by the silver-containing alginated dressing. But the Acrocell AG dressing has a lower list level of the lateral wicking. Now, what about how dressing technique can assist with the silver availability? For the purpose of the antimicrobial, the bacteria should expose to a suitable concentration of liver for enough time and also without the tissue toxicity. But some studies show that antimicrobial activity of the silver is not dependent on the amount of the silver released. So if the bacteria exposed to the very low level of the silver for enough time, normally over the 24 hours, this kind of bacteria could be killed effectively. Even these bacteria were resistant species like the MRSA, VRE. Now, what about how the dressing technique assists with the modulation of inflammation? As we know, the inflammation is necessary for the wound healing, but prolonged inflammation is not good. This kind of inflammation can result in delay wound healing and increase the scar formation. So, for the purpose of optimal wound healing, a kind of dress should contribute to the reduction of the inflammation. Also, in the study with the animal model, the scientists found that if we use a kind of dressing like the hydrofiber, the inflammation was less when compared to the wound dressed by the gauze. Finally, I would like to have a conclusion that viewing all the silver dressings simply as a dressing with added silver view the production efficiency from the too narrow perspective. Second, to make an informed choice, doctors must consider the role of the dressing technology in influence the key factors that promote the wound healing. And finally, not all the silver dressing are created equal, and not any kind of dressing that could suitable to any types of the wound. Okay, thank you very much.
Thank you, Dr. Huang. I think that was an excellent lecture covering the in vivo aspect of silver dressing, from pain to contact concept, ideal moisture, and the concept of quiet inflammation. So now we'd like to move on to some of the evidence that we see in vitro environment. I'd like to invite Phil Bowler to the floor to talk about more concepts and more advances in concepts of silver dressing. Phil?
Okay, thank you, Professor Hong. Good afternoon, everybody. I think in Professor Wan's presentation, he made a very important point that in order for silver to be effective as an antimicrobial agent, it needs to reach the target microorganisms. And of course, this applies to any antimicrobial agent, whether it be a topical antiseptic or an antibiotic. For them to be effective, they need to reach the target site. But in a wound environment, there are many factors within the wound itself and also within the dressing technology that can affect how well the antimicrobial agent works. So in the wound environment, the size, the shape of the wound, the amount of exudate in the wound, the amount of devitalized tissue, the presence of biofilm may all affect how well an antimicrobial agent works. And from a dressing perspective, then there are other factors that again may affect how well, in this case today, how well silver may work. So the type and the concentration of the antimicrobial agent, that may be important. We know that it's less important with silver because more silver does not mean more effective in killing bacteria, because the wound environment itself will dictate how much free silver can be available at any one point in time. But also the availability of the antimicrobial agent from its vehicle. If the antimicrobial agent is locked within that vehicle, then it's not going to be able to do its job in killing the bacteria at the wound surface where it needs to kill them. And also the ability of a dressing to closely contact an irregular wound topography. So if you have a dressing that very closely contacts the contours of a wound, then in theory you're likely to maximise the exposure of the antimicrobial agent to the bacteria at the wound surface. So it's these last 2 points here that prompted us at Convatec to do more research to look at the availability of silver from antimicrobial dressings and also the effect of dressing conformability on how well silver works within these dressings. So the first model that we developed, a very simple model, we call it a simulated shallow wound model. And what we have here is an agar plate, a standard agar plate containing agar, and on the surface of that agar we place 2 pieces of sterile gauze. One piece is 4 by 4 centimetres, and that's overlaid by a second piece of gauze that is 5 by 5 centimetres. At that point, further agar, molten agar, is poured onto the plate. So a second layer of agar is formed, and when that solidifies, we can then, as you see in the central slide here, the central photo, we can remove the sterile gauze, and we're left with an imprint, which we call our shallow wound, simulated shallow wound. It's about 2 to 3 millimetres in depth, it's got a roughened base, and it's got a graduated side. So if you look across the bottom at this cross-section, you can see the graduated side, you can see the roughened base. So at this point, we inoculate bacteria into this simulated shallow wound area. 4 millilitres of a bacterial suspension will completely fill this area. We use either Staph aureus or Pseudomonas aeruginosa, and we inoculate approximately 4,000 cells. At that point, we place an intact dressing, nominally 10 by 10 centimetre square, over the surface of this simulated wound so that it does overlap as it would do in a real wound, so that the part of the dressing is contacting the prominent agar around the simulated shallow wound. So at this point we're looking at the ability of the silver-containing dressing to kill the bacteria that have been inoculated beneath. So we incubate this plate for 48 hours. After that point we remove the dressing and we look for antimicrobial effect. What we also did as part of this study was to place a camera beneath the agar plate in the incubator, and we took photographs every half hour, every 30 minutes, so that over the 48-hour period we could produce a video of what was happening under the dressing. So here we're looking under the agar plate, we have Aquacel AG, which you can see here, and also a cover dressing, which is Vasiva XC. And over the time period, 48 hours, you can see one Staph aureus colony that actually grew beneath the dressing. So 4,000 cells were inoculated, 1 cell of which grew beneath the dressing. So Aquacel AG was pretty effective in killing the bacteria inoculated beneath. If we look at another silver-containing dressing, Alevin AG adhesive, again over 48 hours, you can see that the colonies of Staph aureus are starting to grow over that period in the inoculated, simulated shallow wound area. And again, you do see some lateral spread of the fluid, and you do see some of the colonies on the surrounding prominent agar. And another dressing, Mepilex AG, again over the 48-hour period, where the bacteria were inoculated, you see considerable growth of Staph aureus, but we also note here that there's been significant lateral spread of the fluid and the bacteria onto the surrounding prominent agar, and the Staph aureus has grown in this region of the test as well as where the bacteria were originally inoculated. So we interpreted these results in terms of the surface area growth of Staph aureus and Pseudomonas aeruginosa in this simulated shallow wound area. So if we look at the results here for Pseudomonas aeruginosa, and on the y-axis we have percentage growth for the various dressings. On the left-hand side here you can see the hydrofiber with silver Aquacel AG with very low level of growth of Pseudomonas beneath the dressing. The orange bars represent the silver foam dressings, a range of silver foam dressings under which there was considerably more growth of Pseudomonas. The green bars represent the silver alginate dressings, which did perform somewhat better than the silver foams, but I think because of the different mechanisms of gelling of alginates versus hydrofiber, and the fact that hydrofiber is able to gel much more rapidly and conform to the simulated wound space, then we tend to get better activity with Aquacel AG. We also show results here for the nanocrystalline silver dressing and also hydrocolloid dressing containing silver sulfadiazine. Look at the same results for Staph aureus. Again, the trends are very much the same. The bars are actually lower for Staph aureus, and that's largely because Staph aureus is a non-motile bacterium, so it doesn't spread as much when it forms colonies on the agar plates as does Pseudomonas aeruginosa. But the same trends with very low level of growth of Staph aureus beneath Aquacel AG, greater growth with the silver foams, and you can see the results for the silver alginate dressings, again the nanocrystalline silver and the hydrocolloid with SSD. So in this model, we see that despite the fact that all these dressings contain silver, their effect on killing the microorganisms inoculated beneath are quite different. So here we have another example of Aquacel AG being removed from the agar plate. On this case, we've got 4 colonies of Staph aureus. Alevin AG gentle border here, again with this dressing, considerable growth of Staph aureus and also growth, spread of bacteria on the prominent agar. And we see the same again with Mepilexide AG dressing, with considerable growth where the bacteria were inoculated, but then this lateral spread and growth of Staph aureus on the surrounding prominent agar. But what we also see when we remove this dressing is that the Staph aureus is actually growing on the wound contact surface of the dressing. So we wanted to look further into this aspect, taking away conformability and looking at the effect of dressing technology on antimicrobial action when the dressings were in direct contact with bacteria inoculated beneath. So for this we developed another model which we call a simulated colonized wound surface model. So here we have another agar plate containing sterile agar. On the top of that sterile agar, we pour another layer of agar that is seeded with bacteria, either Staph aureus or Pseudomonas aeruginosa. So this forms a layer of agar about 2 millimeters thick, and the bacteria are embedded within that 2 millimeter layer. So once that second layer of agar has solidified, we place intact dressings, as we did in the last study, over the surface of the agar. We leave the dressings in place for 48 hours, we remove the dressings, and we look for antimicrobial activity. We actually took this test a stage further to look for bactericidal and bacteriostatic activity. So on removing the dressing, if we see bacterial growth in this seeded agar layer, we know that the dressing, the silver-containing dressing, was not effective in killing the bacteria. If there is no growth, no observed growth in the seeded agar layer, then it may be that the bacteria were killed, but it may be that they were inhibited, but they weren't visible. So in order to determine whether the dressing was bactericidal or bacteriostatic, we took a sample of the agar where no growth was observed, transferred this to a fresh agar plate and cultured that plate. If there was then growth On the agar, we knew that the dressing was bacteriostatic, so it inhibited but didn't kill. If there was no growth, then the dressing was bactericidal. So again, looking at the results from this particular test, we have Pseudomonas and Staph aureus. Again, the dressings are colour-coded as previously. Aquacel AG in this model was shown to be bactericidal against both Pseudomonas aeruginosa and Staph aureus. With the silver-containing foam dressings, they had no effect. They were not able to kill the bacteria beneath the dressing. The silver-containing alginates, as well as nanocrystalline silver and a hydrocolloid dressing with silver, were all shown to be bacteriostatic. So they inhibited the bacteria, but they didn't actually kill the bacteria in the seeded agar layer. So we just look at some of the examples taken. Here we have use of Aquacel AG on the seeded agar. So you can see the growth of Staph aureus where the dressing was placed over 48 hours. There is no growth of the bacteria beneath the agar and beneath the dressing, and when we sample the agar, we see no growth. So this dressing was bactericidal in this test. Another dressing, Alevin AG gentle border, see considerable growth of Staph aureus directly beneath the dressing, and the very consistent nature of the colonies here coincide with the pores in the wound contact surface of this particular dressing. Algicite AG dressing, an alginate containing silver. Again, this looks to have worked well. You can see the growth of where the dressing wasn't placed. Where the dressing was placed, then there appears to be no growth beneath. Actually, when you do observe in more detail, you can see some faint growth here. But when you do take a culture of this agar, Staph aureus does grow, Pseudomonas also grows. So this dressing in this model was shown to be bacteriostatic, but not bactericidal. Mepilex AG dressing, there was no effect of the dressing. You can see where the imprint of the dressing was placed, but Staph aureus grew quite visibly directly beneath the dressing. So despite this dressing containing silver, it didn't appear to be effective in killing bacteria in this model. So we took this test a stage further, and we actually sliced a piece of the dressing in half, and we used the edge of the dressing, the cut edge of the dressing, on a similar plate to this one, to see that if you expose the silver in the inside of the dressing, would it then work? So here we have results with that test for Aquacel AG dressing and Mepilex AG. With Aquacel AG, irrespective of which surface you use, whether it's one side or the other side, or it's the edge of the dressing, the silver is always available, and we see killing effect of the bacteria beneath the dressing. With Mepilex AG, on the left-hand side here, this is the wound contact surface of the dressing. So again, as we saw previously, we didn't see antimicrobial action. This is the top surface of the dressing, which appeared to work more effectively than the wound contact surface. But when we do cut the dressing and we place the edge on the plate, then we do see bactericidal activity. So when the silver is made available, it does work. But when the dressing is used as it is clinically, then it appears that it's not able to kill the bacteria beneath. What I'd like to do now is just to move on to talk about multi-drug resistant organisms, the superbugs as we hear about in the press, the antibiotic resistant organisms that are a global problem in healthcare, and an increasing problem. So here we're talking about organisms such as community-acquired methicillin-resistant Staph aureus, Acinetobacter baumannii, which is a big problem in both burn patients. It's a problem in military wounds also, extended spectrum beta-lactamase bacteria, and also Clostridium difficile. These are all organisms that are tolerant, resistant to many antibiotics. Many of these organisms are showing enhanced virulence. and they have an ability to survive in the environment. So they're a big problem. And all these organisms can be found in wounds, particularly in chronic wounds. We, in our own studies, have identified all of these types of organisms in wounds. So, knowing the fact that very few antibiotics work against these organisms, we considered whether Aquacel AG would be effective in actually killing these organisms. And we use models similar to what I've already presented. We use a simulated Colonize shallow wound model. We used a simulated Colonize wound surface model, and we also used a Biofilm model. So we really did challenge the dressing, Aquacel AG, in a number of ways with a number of different models to see whether it was consistently able to kill these multi-drug resistant organisms. So here, examples with Acinetobacter baumannii. Again, the majority of the bacteria, the 4,000 cells that were inoculated, were killed beneath the dressing. Again, we see very good conformability of the dressing in killing of community-acquired MRSA. In the wound surface model, here we have Klebsiella pneumonia with very good effect of Aquacel AG against it. Klebsiella pneumonia is one of the extended spectrum beta-lactamase bacteria. And again, below that, we're looking at community-acquired MRSA. Again, very good activity. We also used a biofilm model called a poloxamer model, which we published on previously, in which we can actually grow bacteria in their biofilm phenotype. So this encourages the organisms to behave in a sessile way as they would be found in biofilm. So it's their most tolerant form. But again, with Aquacel AG, as you can see here against Acinetobacter baumannii, in its biofilm form, we see good activity, inhibitory activity of the dressing, and below against Clostridium difficile. This work actually has just about been published in the International Wound Journal. It's available online. It should be online now, and it will be published in the journal around August time. Slide still. Okay, finally, I'd just like to talk briefly about another chronic wound type that is largely unknown, and that's the Burrowing ulcer. Burrowing ulcer is a chronic wound, as you can see across the bottom of this slide, very nasty wound that exists in all ages and in many parts of the world, certainly in underdeveloped parts of the world, tropical and subtropical regions. And you can see some of the areas of the world, West Africa, parts of Australia, Southeast Asia, China, Central and South America, where it is endemic. This particular ulcer is not caused by an underlying pathology. It's caused by one particular bacterium called Mycobacterium ulcerans. So it's the same family of bacteria that cause tuberculosis and also leprosy. And it's now the third most recognized mycobacterial disease in the world today. The World Health Organization recognized Burrowing ulcer as a neglected tropical disease. The mycobacterium itself is a very unusual bacterium. It's got a very tough lipid cell wall. So not the commonly used antibiotics are effective against it. So we didn't really expect that if we tested silver against this organism that it would work. But we used the models that I've already described to test the efficacy of Aquacel AG against this particular organism. In our models, we didn't use Mycobacterium ulcerans, which is the cause of Burrowing ulcer. We used Mycobacterium fortuitum. The reason for that is that this is a faster growing species. Mycobacterium ulcerans grows very slowly, so it's very difficult to handle in the laboratory. But physiologically, it's very much the same. So, using the same models that I've described, the simulated colonized wound model and the wound surface model, again, use of Aquacel AG, we see no growth of fatuatum beneath the dressing. This is the control, so this is Mycobacterium fatuatum growing in the absence of Aquacel AG. And in the colonized wound surface model, again, we see very effective activity of Aquacel AG. So this particular wound type is neglected. It exists in the more rural parts of the world, underdeveloped parts of the world, and there are very few treatments. Surgical debridement is used, antibiotics if they're available, but to date no dressing treatments have been shown to be effective or have been tested. So Aquacel AG may be effective, may be helpful in improving the lives of these patients. So I'd just like to summarise in terms of the in vitro evidence that we have today. We know that the hydrofiber technology is very effective in terms of its exudate management. So Aquacel and Aquacel AG dressings are very effective in their absorption of exudate and also the retention of exudate. We know that that technology is also able to trap bacteria within the dressing. So the movement of fluid and bacteria into the dressing is essentially one way. The fluid and bacteria don't go back into the wound. And we've demonstrated killing of bacteria within the dressing. But we've also demonstrated the availability of ionic silver from the dressing, and we've shown killing of bacteria at a colonized wound surface. In the latter slides that I've used today, we've shown activity of Aquacel AG against multi-drug resistant organisms, a variety of antibiotic resistant organisms that are problems in healthcare today. And finally, activity against some atypical wound pathogens, such as Clostridium difficile, such as Mycobacterium ulcerans, and also Propionibacterium acne. This is an organism that naturally lives in the deeper layers of our skin, but it is more increasingly associated with surgical site infections, particularly following orthopedic surgery. So with that, that's my final slide. I've based the presentation on a number of references which are shown here, so thanks very much for your attention.
Thank you, Phil, for that wonderful lecture. And also thank you, Dr. Quan, for the presentation of your experience using silver dressing as well. We now like to open any questions to the floor and to the audience currently listening to the webcast. So please, when you ask a question, please present yourself and the question. Yes?
My name is Haris from Malaysia. Prof, just now is quite interesting that you mentioned to us it's not the concentration of the silver does not determine the effect of the silver dressing. It's more towards the how much the concentration is maintained during the period of dressing. Can you please explain further on this? What is the basis on this? And Mr. Philip, I want to extend the same principle to this dressing. We basically advise, or probably we use the protocols of maintaining the silver dressing for 5 to 7 days. And it's quite interesting from your data just now that even at 48 hours, there are differences in the colonization of different dressings. We would like to know, are there any in vitro evidence of the extension of these properties exceeding 48 hours up to probably about a week? And then I just want to know, basically we know that in the real in vivo situation, we have exudates. And we know that bacteria thrives in these exudates. Do you think that these added benefits of Aquacel because it traps the exudates inside the exudate inside the dressing, in part of what you have shown in vitro that it basically kills the organism by the way of maintaining microbial bactericidal effects. Thank you.
Shall I start? Yeah. Okay. Thank you. In terms of the length of time, absolutely, Aquacell AG, we've demonstrated this, we've published this using very stringent models, not the ones I've shown today, but using very stringent models. We've shown that Aquacell AG can continue to produce silver and kill bacteria, including antibiotic-resistant bacteria, over 14 days. We did this initially for the indication for partial thickness burns. For chronic wounds, the maximum wear time is 7 days, but we know that in a very stringent model that simulates an excess of exudate, then the dressing will continue to work. So hopefully that answers that question. In terms of exudate, absolutely, exudate is essential for silver to work, certainly. So if the wound is dry, you need it to create an aqueous environment to trigger the silver, to get the silver to work. And ultimately it's the availability of silver ions in the wound, because ionic silver is the effective form of silver. It's the availability of silver ions that are required. So with Aquacell AG, it's designed to absorb and manage exudate very effectively, which it does. We show that it kills in the dressing. It also kills at the wound dressing interface. In the second model that I showed, the wound surface model, we do have a 2 millimeter layer of agar seeded with bacteria, and we see complete killing through that. And there is sufficient moisture there to elicit that type of reaction. I'll go on to the concentration of silver also. It's right that ideally a dressing needs to be able to continually provide sufficient silver over the wear time of the dressing. I did say in my presentation that more silver does not mean more effective, and that's absolutely the case, because the wound environment itself will dictate how much free silver, ionic silver, can be available. Chloride ions are absolutely abundant in wound exudate. They've got a very strong affinity for silver ions, so they very rapidly bind together to form silver chloride that's not effective as an antimicrobial agent. So there's only a low level of silver that can be ever available at one point in time to kill the bacteria. So it's that constant provision of the low level of silver over time that's required to provide the killing effect, and Aquacell AG does that very effectively.
Just continuing with the bactericidal model, is it my understanding that the colonized wound surface model is the first of its kind to actually show that effect against being bactericidal?
Yes, I'm not aware that model has been used previously. We developed that in our laboratories, and I'm not aware of similar work anywhere else.
So if you look at that model, you had that 2 millimeter depth, and you're actually taking the bacteria samples beneath that 2 millimeter surface, correct?
Yes.
So is it safe to presume that this would be the similar situation in vivo, where I think as a clinician, whether silver being penetrated will be able to penetrate into the wound surface to really kill that bacteria beneath the surface is a very important issue.
Absolutely. In this model, as you rightly said, Professor Holm, the seeded agar layer was 2 millimeters in depth. All the bacteria directly beneath Aquacell AG were killed. So that must mean that silver is available, was delivered and was available in that 2 millimeter layer of agar. Of course, the wound environment is very different. It's much more challenging. So the amount of exudate, as I mentioned earlier, the viscosity of the exudate, the amount of devitalized tissue can all affect that penetration and availability of silver. So I think for use of any antimicrobial dressing, to give that dressing the best chance to work, prior good wound bed preparation, sharp debridement, cleansing, is essential to give that dressing the best chance to work.
Thanks, Phil. I think this is amazing. Good progress. Just going back to the webcast audience, John Spears from UK. Are there any products in the market that will give the same or similar effect as Convatec silver dressing? Phil?
Well, there's no other dressings that contain hydrofiber technology. Hydrofiber is proprietary to Convatec. So what I would say is that the physical properties of Aquacel AG are absolutely unique. So the way that the dressing absorbs fluid, the way that the fibers gel, form a very cohesive gel, is absolutely unique. Also unique is the relationship between the silver ions and the dressing itself, because the positively charged silver ions are combined with the negative charges on the carboxymethyl groups of the dressing itself. So the dressing almost wants to hold on to the silver, but when you have a very challenging wound environment, lots of bacteria in the wound that all have negative charged sites on the bacterial cell surface, they're essentially pulling silver ions away from the dressing. So no other dressing works in that way.
Thank you. Questions? Okay, I think as a clinician, we always because of the advances in wound treatment, I think some of our colleagues in Korea are starting to use stem cell therapy, and also other cell therapies to really heal the wound. So the question is, and I see this question also from the webcast, what is the effect, the cytotoxicity against normal cells while using silver?
Well, there's always a concern that antiseptics generally can be cytotoxic. I think the reason that we see such widespread use of silver today is that its toxicity profile is very low, and it's much better than other antimicrobial agents such as iodine. So the safety efficacy profile is very good. I think in vitro tests there has been some effect shown against the likes of fibroblasts. Again, in our studies that we've performed, we've tried to simulate the wound environment as best possible. So we use a fibroblast gel contraction model where we embed fibroblasts within a collagen gel, and we look at the contraction rate of the fibroblasts showing healthy fibroblasts over time. And we see, particularly with Aquacel AG, we see very little effect. So there's really no toxic effect with Aquacel AG. And certainly to use in conjunction with the likes of living skin equivalents to help to maintain that aseptic environment, to help to maintain a low bioburden while those cells start to take on the wound, I think is a useful combination.
Thank you. Gentleman in the front.
Yikai from Singapore. I've got a question for Mr. Bowler basically. And how do you explain the fact that silver in hydrofiber is bactericidal and AG in the other dressing is only bacteriostatic or has no effect?
Yeah, no, absolutely valid question. And again, I think, don't know for sure, but I think it's the relationship between the hydrofiber and the silver. So what we saw with some of the foam dressings, the silver-containing foam dressings, is that there appears to be some sort of barrier there which prevents the full availability of the silver from the dressing. More closely related are the silver alginate dressings, because they are absorbent. The fibrous dressings, the more absorbent, are more comparable with hydrofiber. But at the same time, alginates do not gel as effectively as hydrofiber. Hydrofiber gels very quickly, forms a very cohesive gel, and I believe that because you have total exposure of those fibers to the bacteria beneath, and you've got a very effective gelled matrix, the contact is 100%. So I think that relates to the bactericidal effect under Aquacel AG, whereas with some of the alginate dressings, because you don't have that as effective gelling effect, then you don't necessarily see total bacterial killing beneath those dressings.
Questions? Gentleman in front.
Hari Krishna from Malaysia. I'm quite interested in your previous studies, where you showed that most of these wounds have got microbial soups. And now the thing is, the interesting part about biofilms, because they're becoming a very big thing. And you showed about Acinetobacter baumannii and also Clostridium difficile in this. Now there's a few things about biofilm that you look at. Number one is basically to cut down the biofilm. And number two is to prevent the recurrence of biofilms, which is becoming a very common thing. Do you have like any studies per se? Especially nowadays we find that we use the confocal laser scanning microscopy to make sure that we can actually look at the biofilm easier instead of just using clinical assessments or even coming out with specific EGA plates and all that. Can you basically touch on that, since this is becoming a growing problem with most wounds, since everything is coming out with lots of biofilms in. Thank you.
Yes, thank you. Absolutely. Biofilm in wounds is a big and emerging topic in wound care today. Certainly there is concern that biofilm is a problem, and I think there's a lot of evidence now to show that biofilm does exist in virtually all chronic wounds, and that it is a barrier to healing. There's evidence now that it prevents granulation tissue formation, it prevents epithelialization. So to recognise biofilm and to do something about it is extremely important, I think. Today, there are no products that are directly available to deal with biofilm. I think the whole area of wound bed preparation and maybe the sharp debridement is very important in helping to reduce that bioburden. Ways to detect biofilm in a wound, there are, again, to my knowledge, I think there are certain research groups that are looking at this, but ways to detect biofilm, there's nothing available today. But with a nursing practitioner in the US, I did recently publish an article in the Journal of Wound Care looking at the visual appearance of biofilm in different wound types and how that biofilm relates to other underlying pathologies. So I think to a trained eye, and in certain types of wound, biofilm can be visualised, absolutely, but more techniques are required to better determine biofilm in wounds, certainly. But yeah, a major discussion point today, and dealing with biofilm, I think, is very important.
Thanks, Phil. Just switching gear, we have another question from our webcast audience. I'd like to address this to Dr. Quan. Have you seen any side effects while using silver dressings, clinically, or like dermatitis?
Yes, and in China we have many burn patients and the wound like the second degree and first degree wound, and also we have some chronic ulcer. So in recent years we have used hydrofiber dressing like the Etrocel AG. So I think these were useful because it can. In China, most of the burn patients, we first used the SSD, but it is painful. So we recent years we used fiber dressing, Etrocel AG. So especially in the kids, in the children, so it is quite good. I think it's good. Also, and when we used in this kind of wound. I think the infection of the wound will decreased, and sometimes. But if these kind of wound have existed the infection, I think maybe use this kind of dressing have the effect is not effectively sometimes like this. And also, I just wanted to discuss with something about the biofilm, just this professor to think about it. And my student last year to do some experiments about the biofilm, we found some topic agent when used with the biofilm. This kind of topic agent cannot kill the bacteria inside of the biofilm totally. So I just hear Professor Burrowing show the slide that if this kind of the dressing, aqueous age dressing can have effectively on the biofilm bacteria, I think this is quite a good thing. Yeah.
Yeah, well, we published two articles relating to use of or efficacy of Aquacel AG against biofilm bacteria using two different models in the laboratory, and there is definitely some effect that Aquacel AG has worked. I wouldn't say Aquacel AG is the solution to biofilm in wounds, absolutely not, but we have shown that it does have some effect in dealing with biofilm in vitro models.
Thank you.
To add to that, because the thing is, you've already showed in the previous slides how Aquacel AG has worked remarkably in terms of bactericidal effect on organisms and all that. And we find in biofilms, these organisms actually work with quantum sensing and all that, and they are below the biofilm stuff. And most strategies are basically for debridement. I mean, they've used a bit of other products and all that, but basically debride, I mean, the same thing as what Gary Siebel has talked about wound bed preparation and all that. Following which, when we put actually Aquacel AG on top, if it basically kills off these organisms which are actually causing the formation of these polysaccharide biopolymers, it actually would be quite remarkable to be used. So one thing I would add actually.
Absolutely, and I think dealing with biofilm, it's a continual process because biofilm will form very quickly, whereas slough or devitalized tissue forms slowly. Biofilm can reform overnight. So, and you're not going to get rid of biofilm completely from a wound. So during treatment of the wound, it may be sharp debridement, it may be cleansing agents, certain oxidizing solutions have been shown to have some effect against biofilm. So that can be helpful as a cleansing process to remove. But then use of a dressing that helps to stop the biofilm reforming, I think is very important, and Aquacel AG certainly could have some benefit in that respect.
Okay, one final question from our webcast audience from China. Is there a time guideline for using silver in wounds, if any? Dr. Huang or Phil? Is there a time guideline? Is there a time guideline for using silver?
Yeah, time guideline. No. What I would say is that using silver as an antimicrobial agent, if the wound has not progressed over a 2-week, maximum 3-week period, I think the protocol of care should be reassessed, because you would expect that the silver dressing, if it's an effective silver dressing, would be helping to improve the status of the wound. But of course, it's not the dressing on its own. It's the whole process of wound bed preparation, use of the dressing, and in that respect, you should start to see improvement within a 2 to 3 week period, if not review the protocol of care.
All right, thank you, Phil. I think we've covered very interesting subjects. Clinically, we talked about Aquacel AG fiber being helped against pain and really obliterating that dead space because of that increased ability to conform and to contact in wounds and provide an ideal moisture. And we also heard about sustained release of silver in these dressings, and also the concept of reduction of the active inflammatory phase called acquired inflammation. I think we also heard about silver being bactericidal, and also the possibility of penetration in these chronic wounds. I'd really like to thank the two speakers who really shared their experience and their evidence in using silver against these tough wounds. And I'd also like to thank the participants, the webcast audience, and Assam Medical Center, and most of all, Convatec, for putting up this wonderful webcast. We've had over 50 questions from our webcast audience, and we couldn't provide all the answers, but I'm pretty sure that we'll be able to provide you with answers through our homepage or through your personal emails. So with that, I'd like a final applause to our speakers to end up this webcast. Thank you. All right, thank you. I think we have some housekeeping announcements. BK?
we will have a group photos, and we'll have a group photos. So please stay outside, and Dr. Hong and I guide you to the place for group photos. Thank you very much.